There you go. Thank you.
Decoration Day.
You're the one who brought it up.
Isn't that an English thing?
Poppy Day, we call it. Remembrance Day. Remembrance Sunday or Poppy Day.
Yeah, but in your note, I thought you said in England it was known as Decoration Day. It was known as Decoration Day here also until, I don't know, 1950s.
No, it's known as Armistice Day. In my note, I said Armistice.
That too. Oh, you did? Okay.
Armistice Day or Remembrance Sunday or Poppy Day. Any and all of the above.
Oh, you're making my head hurt.
I'm so sorry, Mr. Hannum.
Hey, Jake, I saw the devastation in this flash flood in a town that's probably near you. How are you?
Yeah. Oh, yeah, we're fine. Excuse me. Ellicott City is about 10 miles down the road from me.
Uh-huh.
And but we had some heavy rain here, but no flooding as far as I know. In our town.
Right. Good.
We have another phone caller. Who's on the phone?
Neville Black from Australia, Rick.
Oh, Neville. How are you? I was just thinking of you because I saw that picture of the hoi polloi from Prostate Cancer of Australia, and there you were in the background there, in the back row, I should say.
The background's the best place to be, Rick.
Always. Damn.
What was the name again? What was the name again, please? Neville Black.
Neville Black.
Yeah. Yeah. And where was our buddy Jim? He wasn't in that picture.
No, he wasn't. He didn't get a free invite.
Okay. Who's he been upsetting now, Nev?
Pardon?
Who has he been upsetting now?
No. It was just an invitation-only event, and he wasn't able to make it on that particular day. It was actually in Melbourne. It was in Melbourne, so it wasn't local.
Mm-hmm.
It was at the Peter MacCallum Cancer Centre, and they're heavily involved in the lutetium trial in Australia.
Oh, right. Okay. Yeah, that's where I sort of went there because a lady from Miami posted on your site about the lutetium trial. So I told her, I invited her to come to the group, and we could tell her what we knew. We got a couple of guys that are involved in with lutetium right now. So anyway.
Yeah, I'll talk about it later anyway. Yeah.
Okay. And someone else on the phone?
It's probably Peter. My GoToMeeting just messed up. I can't get on there.
Okay, it is you. And it shows that you're still there, Peter, but that's interesting.
We saw your video a minute ago. And then
I was on, and then it locked up and told me I had no audio. I couldn't hear you guys, and so I tried to get out.
I think sadly it may have something to do with the internet speed, because sometimes I have that too here, Peter, because I don't have very good download speed.
Could well be.
So, but we can hear you loud and clear on the telephone. And
someone else just joined on the telephone.
This is Sylvester. Hello, everybody.
Hello, Sylvester.
Hi, Sylvester.
Okay.
Okay, we can start now. Sylvester's here.
Thanks for waiting.
It's always our pleasure, Sylvester. You know that. Okay, well, I will do the roll call at this point. I don't see anybody new, which is good. So we got Peter Kafka, Dennis Correa, Dan Louie, Jay Krugman, Len Sierra, Paul Frieda, Jake Hannum, John Appler, Ken Anderson, Neville Black joining us from the other side of the world in Australia, Spokane, Gary Gunville, Spokane Gary, and Sylvester. Anybody that I missed? Okay, well, that's good. So let me run down and see who would like some time today. If in the next 5 minutes or so anybody new joins us, then this, we may give them priority to talk a little bit. If they come in the first 10 to 15 minutes, we'll give them priority. Otherwise, it'll be catch as catch can for new people. Okay, Peter, anything that you'd like to discuss tonight?
No, I don't think so.
Okay. Dennis Correa, anything you'd like to talk about tonight?
Yeah, if somebody has any kind of an update on the Zytiga generic product that's supposed to be out this year,
Right.
or anything regarding anything in the works for the Zytiga clinical trial phase 3.
All right. We'll come back to talk.
Okay.
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 Dan Louie, you said you had a couple of things you'd like to discuss.
Yeah, basically resuming the discussion from last time I participated.
Sure. Okay, we'll get to you. Jay Krugman, anything for you, sir?
Nothing this evening, Rick. Thank you.
Okay. Len, anything for you?
No, thanks, Rick.
I'll give you a bit of an update, Rick, later on if you like. Yeah.
I'll go through the whole list and we'll come to you, but we definitely would like to hear from you.
No worries.
Paul Frieda, anything for you?
No, I'm good, thanks.
Okay, Jake, anything for you?
If there's time, we can
There's
go.
time.
I can give you my latest blood results.
Yeah, there's time. John Appler, anything you'd like to talk about tonight?
No, I'm okay, Rick. Thanks for asking.
Okay. Ken Anderson, anything that you'd like to discuss?
Nope, I'm good. I'll just listen in.
Okay. Nev, we'll definitely come to you for a little update and a little briefing on yourself and also on what's going on down under. Gary, anything for you?
Yeah.
Okay.
I'd like to join in.
Yep. Okay. And Sylvester, anything for you?
No, thank you.
Okay. All right. So I've got it. We should have plenty of time. We'll kick off with Dennis and then go to Dan, and then probably to Nev, in that order, and then we'll see where we stand. Dennis, you were asking about the generic Zytiga, which Jake is always good enough to find the link to. Have we heard any developments about it being available, and also about any possible Zytiga trials? In what context?
The reduced dose with food with a low fat breakfast.
Okay. So I certainly don't have I haven't heard of anything new on either score. I do know that there were trials already on the reduced dose with food, but I think, if I'm not mistaken, they were small trials.
Yes, there was a phase 2.
Yeah, phase 2. I haven't heard about that. We would have to take a look, do some research, and see. Have you looked on clinicaltrials.gov?
Yeah, I didn't see anything. I just wonder if it was in the works or it hasn't even been formulated or thought about yet.
I think it's been formulated. For some reason, and I'm not sure why, I seem to think that they were doing something at UCSF on that, but I'm not sure. I would have to look later. But I'll throw it open to see if anybody's got any thoughts on either the generic or the lesser dose when you take with food in terms of having more evidence.
This is Peter. My internet's down, so I can't verify it. But the other day, I did see some post on Health Unlocked where someone was talking about a new alternative to Zytiga, and it had a name, but I didn't copy it down. So I assumed it was public information by this point.
Yeah, I can't remember the name of it either. Actually, I'm looking at Mike. I'm looking at Mike Scott's post from January, and he says there are 12 companies who want to submit approvals or ask for approvals, but none of them have been approved yet as of January.
Right. Well, this was just the other day. I saw it, and then the person's comment was, "Why would anybody want to take Zytiga when they can get this for a fraction of the cost or something?" Yeah, they didn't mention the name of the drug.
I want to say apalutamide, but I know that's wrong.
No, it wasn't. No, I would have recognized that.
Apalutamide is
I'd never heard of.
Drug.
Yeah, it's a different drug.
I mean, it's definitely the case that Zytiga is supposed to be going generic this year. It's going off patent. But then there was some, I seem to recall there was some talk that they were trying to extend the patent with some, I don't know, some weird Mickey Mouse stuff. I'm not really sure. I will make a note to myself when I've been trying to talk with Carolyn Pavis, who is the I'm not sure of her. I think it's Director of Patient Relations or something like that for the Oncology Division of Janssen. So when I do, I've got a list. Look, in fact, what I'm going to do is I'm going to put this right on my list. I'm up to 11 I've got 11 things to talk to. So I'll ask her about generic developments for.
Thank you, Rick.
And I'll get back to you. I mean, I thought we were going to talk on Friday, but it didn't happen. So, but we will definitely talk within the next 5 to 10 business days, and I'll ask her about that, see where they're going or what they know. I mean, I guess they're going to know when their sales start to go down significantly.
Right.
So,
yeah, that's really all I had, Rick. I'm gonna be seeing my local doc here tomorrow for my 90-day Lupron injection.
Right.
And so I thought I would raise it with him if anybody's got anything new on this Zytiga stuff.
Has anybody on the call tried taking a reduced dose of Zytiga with food?
Rick, it's Nev in Australia.
Yeah.
We've had guys in Australia take one tablet with food, especially before it come onto the free, the $5, $30, depending whether you get on the PBS. We have a PBS system in Australia for drugs where the government pays most of the cost. But before it went onto the PBS system, guys that couldn't afford between $3,000 and $4,000 a month, they were buying 1 month's supply and then using it over a 4-month period and taking it with food. And it does the same job with food, but I think it's a lot harder. You have to take great care with your liver. Your doctor needs to know, and they need to do a lot of liver tests and all that sort of thing. So yeah.
Right. I think it's correct me if it's either 3 to 1 or 4 to 1. You can go to, is it either 25% or a third of the original?
25%, right?
25%, yeah. Because the Zytiga is absorbed through the liver, and
this to be taken with a low-fat breakfast. which was not really defined. So I don't know. I'd have to do some research on how they really define a low-fat breakfast.
Mm-hmm. Yeah, I mean.
Hey, Rick.
Yes.
The alternative formulation, this is not generic Zytiga, but there was an alternative formulation called Yonsa, Y-O-N-S-A.
That's
it.
That's what I read about.
Yeah, that was just approved by the FDA. It supposedly has double the bioavailability of Zytiga. I'm not sure what their comparator is, if they're talking about Zytiga on an empty stomach or Zytiga with food, probably an empty stomach.
And I believe a gold star for you, Len. I couldn't remember the name, but I believe it's used with methylprednisolone, I think, instead of prednisone, if I remember correctly.
Right, but basically it's the same drug. One gets converted to the other inside the body.
But a different steroid. I don't know if that makes a difference.
It's basically the same steroid, the same drug. I think it's methylprednisolone gets converted to prednisone once it's taken orally, or vice versa. I can never remember which, but in any case, they're interchangeable. I'm not sure why. Maybe it was just easier to use methylprednisolone in the formulation.
Sounds more impressive because that's even harder to pronounce than prednisone.
Yeah, right. It does. $25 word.
Thanks.
For real.
Thanks for that. Okay. Listen, it sounds like we have a new Ken Mason wannabe on this call, Len.
Who's the Ken Mason wannabe?
Jake. He's providing the.
Oh, Jake?
Well, I've gotten into the habit with inner conversation, so.
I can see. That's what was going through my mind. We pulled this man right out of his shell, and it's wonderful.
I don't know about that, but.
Yeah, Yonsa is definitely the formulation that's been around for a while. And Peter, you say that you just saw that got FDA approved?
Well,
Yes.
I read something about it on Health Unlocked. Someone did a post on it, but I don't know if it's FDA approved or not.
Okay.
Yeah, I'll put a link in the chat box.
That would be great. What I would like to know, if anybody's seen anything on the pricing.
No, I haven't.
No. And there was, or if anything was released on the pricing. So, okay. All right. Well, the information, certainly the information from Nev was really helpful. I mean, I have not heard. This conversation goes back probably 3 or 4 years. I suspect if you look at Mike Scott's site, the first reference you'll find to abiraterone and food, and I have it, I just can't look for it right now, is probably 3 to 4 years ago. And in that time, I haven't heard of any adverse effects. I mean, that's purely anecdotal, of course, but I haven't heard of any adverse effects. You know, I think, and some of our guys have done this before, Dennis. I mean, I definitely think it's worth a discussion. I mean, print out the trial and the commentaries and give it to your doc. Now, that, of course, is if, you know, what are the benefits to you? If it's financial, clearly there's a big benefit. If it's not financial, then it's just really one of convenience, in that you don't have to get up early and take the meds and then wait to eat and all of the rest of the stuff. But if it's
It's both of those, Rick, as well as my general concept of not having to take any more drugs than I need to do the job.
good point. Yeah. Well, let us know how you do with it. Have you ever tested out Dr. Singh's response on this?
No, I haven't, but that's when I see my local doc, he will confer with Dr. Singh on it, and we'll see what they think about it.
Make sure you
Rick,
just one sec.
when I started a couple of months
Peter,
ago,
just one sec. Just let me just finish this thought with Dennis. Dennis, I would send, if it were me, I'd send the research to Singh as well, so that he doesn't get blindsided by the local guy.
Yeah. Good idea.
Okay. Sorry, Peter, go ahead.
Yeah, when I started Zytiga 3 months ago, I was in Dr. Turner's office and I had this discussion with him. He was well aware of the studies. He was very familiar with them, and I asked, what's up with this? What about it? And he said, yes, he has some patients that do the reduced dosage, and they do it for financial reasons. But he would like me to just stick with 1,000 milligrams with no food.
Mm-hmm.
So I didn't press him beyond that, but he was very clear that that's what he wanted from me.
Okay. And that's good. I mean, that's what we're looking for. Any feedback on discussions that anybody's had with their doctors about reducing the dose and taking the Zytiga with food. So, well, let us know if any of you do have this discussion. Please let us know, what the docs say, and let us know if any of them approve you going onto the lower dose with food, and then of course how you do with that. It's only anecdotal information, but it's always helpful to others.
Rick, can I just say a word about that again? Ned from Australia.
Yeah.
The guys on Australia that were taking Zytiga of our own without food, or with food, sorry, didn't do it longer term because it did become on the PBS system. So there wouldn't have been anybody on it for more than 12 months, I don't think, in Australia with food sort of thing. And then it became available on the PBS, so those guys would have just all went to 4 tablets an hour before breakfast or whatever.
Mm-hmm. But the guys who did it for, whatever it was, 6 to 12 months, didn't seem to have any adverse effects.
Well, I don't really know, but I know they were told that their doctors were watching their liver all the time. I never heard of anyone that had a real problem with it, but I do know they did blood tests all the time on their liver, sort of thing. Yeah, just to make sure it didn't get out of control.
Okay. All right. Well, we'll move along. We've got a couple of new people that have come in, and I'll just check in. I know that Rich Jackson was kind enough to send me a note saying he's just listening in. It doesn't have anything to raise. Larry Fish just joined us. Larry, how are you? Anything you'd like to talk about today?
Yeah, hi everybody. Nothing special. I'm okay today.
Good. And then we have somebody else that's joined us on the telephone. Who is that?
That's Roy Savrick.
Ah, hello, Roy. Well,
what was the name again?
Roy.
Roy, go ahead.
Roy Savrick, who's a friend of Peter's, or who Peter has spoken to, and this is the first time I know that you're on the call. So you just about snuck in under the wire here, because I thought we may have one new guy. So before we go to Dan Louie, and we like to try and give brand new guys a preference to tell us a little bit about your disease. And since we don't have a lot of people that need time tonight, I think we definitely have time to talk to you, Roy. So why don't you, Peter, maybe you'd like to introduce Roy and then let Roy talk a little bit.
Yeah, Roy and I met on the phone for the first time Saturday. He called me up. He's a good friend of a friend of mine here on Maui. And I'll let him speak for himself. He's got, sounds like pretty advanced disease. And he's looking at various options for treatment. So I'll let him speak for himself. It's I think that's the best thing to do. He lives down in Florida.
Okay. So Roy, tell us a little bit about your age. Probably much of what Peter asked you to tell him. Your age, your general health background, the disease, the history of your disease, and where you're getting treated, and the details of your disease, and then whatever questions you might have, and we'll try and address them.
Okay, so I found out in March that I was Gleason number 9. Did a bone scan and a CAT scan, and it hadn't spread at all. I was encouraged to take a Lupron shot because the number 9 scared all the medical people I spoke to. So I did that on April 12th of this year. So it'll be 2 months on June 12th. The only other thing I've done is I've been talking to some proton centers. I went out to Loma Linda, and next week I'm going out to the folks, the California Proton Center in San Diego. The only question maybe I had, if someone can give me some feedback, on the CAT scan, it showed a lymph node that was 6 millimeters, and they wasn't sure if it was, spreading from the prostate or it was a result of a TURP operation that I had, months before this, which is, so that's the one thing I've been contending with. And then I thought maybe from talking to Peter that there was a process called Axumin, an imaging center that maybe could find out if that lymph node was active or not. And then I heard today that because I took the hormone shot, maybe it couldn't be done. So that's something, and I wanted to give some direction to the folks out in the Proton Center and get their feedback, which I'm doing next week. So I think that's the long and short of it.
And Peter, I know that you've been looking very carefully at proton versus regular beam. What was the tone of your discussion with Roy over proton versus IMRT?
Well, Roy's done quite a bit of research. I mean, he knows that Loma Linda is kind of out of date, even though it was one of the pioneers in the process. He knows that Dr. Rossi at California Proton is one of the most experienced guys. Mm-hmm. He's also well aware that the proton industry is kind of going bankrupt right and left, so that they are promoting their therapy probably more than anything else to keep it afloat because of the expense of the operation. There's a couple of things Roy mentioned to me that if it's okay with you, Roy, I might bring up too.
Sure.
He's done a lot of preliminary work in this. He did get a second opinion from Dr. Epstein, right, on your pathology? Yes. Yes, and Dr. Epstein came back at a 5+4, which is why some of his oncologists why some of his urologists are alarmed. And I suggested, as long as he's going to California, that Roy might want to check in with prostate oncology specialists or get an oncologist, because I don't, at this point, he doesn't have one, just to kind of look at, options as he goes along.
Mm-hmm.
So, and the other thing that's unusual is that, Roy indicated to me that he's got a low PSA, that he wasn't driven to, he had a TERP because of urinary issues, but his PSA has remained low, I think around 3 or something. So that's another odd issue with the thing, that PSA is not a big indicator for him.
Okay.
So those are just things I want to mention.
So, I mean, I have some thoughts, but, and of course we'll throw it open to everybody, but is there anything else? How old are you, Roy?
I'm a young 72.
Okay. Join the rest of the young crew on this. Is anybody old? Is anyone old on this call? Look,
Not today.
amazing
but
size.
Roy is in good shape. He works out and he gets a lot of exercise, so he's in top shape.
And which is great, because that's something that is really, really important for you to keep on doing. Is there anything else you'd like to add to the information you've given us, or are you ready to hear a few thoughts? And just remember, advice is what you pay for it. We don't give advice. Sorry, I shouldn't have said advice is worth what you pay for. But we all have opinions, and everybody knows what opinions are like.
Yeah. I think I've given you a reasonable, broad stroke picture. I'll be curious what everyone thinks. And what concerns me is something that Peter had mentioned, that someone had come back from San Diego doing, the basic proton pencil therapy and was incontinent. So here I am, going next week and maybe signing up to go there, and I'm trying to protect all the other crucial parts of my body from collateral damage. So that's the main concern that I have.
Well, let me kick off. I don't want to alarm you, but my experience, which goes back now probably a good 10 years, is that when you see a PSA as low as yours and a Gleason as high as yours, it normally indicates a very unusual type of disease. And based on the experience, and I can refer you to men who fit that pattern. Unfortunately, one of them is not on the call today, but I encountered him about 5 years ago, and he's had a pretty rough ride, and some of his options are now running out, but he's certainly been around for longer than 5 years. Now, I would advise, if it were me, and I had numbers like that, I would be getting a GU medical oncologist on my team immediately. And it wouldn't be prostate cancer oncologists, not that I have anything against them. I think they're very good, but I also think that they fit in a certain niche, and that niche works well for Peter, where he got treated at a center of excellence and he wanted to go beyond. But I think that your GU Med Onc, genitourinary medical oncologist, should come from a center of excellence where they have access to a larger database of men who have faced this particular type of combination of disease. And frankly, given where you live, I would suggest that you make an appointment with Paul Korn at MD Anderson, because he is compassionate. He's an outstanding, he's certainly in the top half dozen, if not the top 10 medical oncologists in the country. Very, very smart, very savvy, and his antennae are going to be up when he hears about this combination. And I think that he will help guide you with treatment. I don't know that I would dive right into PBRT right away. Personally, I don't see that there's any advantage to PBRT. The only test that I'm aware of where it's been tested head-on with IMRT, and I have that reference. It turned out after time that the IMRT had greater comorbidities in the rectum and the bowel, and the PBRT had greater morbidity in the intestines. So it was 6 of one and half a dozen of the other. I don't have a lot of information, or I can't offer you much experience on pencil beam, proton beam therapy. Just don't know that much about it. I do know a little bit more about SBRT in general, CyberKnife or what have you, but that's with, I believe, with a regular beam. But before I did anything, before I dove into primary treatment, and I think primary treatment may well be the right way to go, but before I dove into primary treatment, I'd be wanting to talk to a really good GU med-onc about this type of disease, because it's really unusual. And a lot of times, what Jim Harrington isn't on the call today, right? No. We've got several people: Eric Bookbinder, Jim Harrington. I'm trying to think who else. Those are the first two names of people that have had low PSA and high Gleason scores when they got diagnosed. Eric was not. There was no evidence of metastasis. I think there was with Jim. I think there was with Jim, but I'm not sure. So let me just ask, is there anyone on the call today who was diagnosed with a very high Gleason score and a very low PSA? Okay. Let me throw it open for other people's thoughts and opinions as to how one might respond. If it were you, how would some of you respond to this type of disease demographic? Oh, I should ask you, how many of your cores were positive? What were your biopsy details?
There was no biopsy. There was they took a specimen when I did with the urinary problems from the TERP. So they removed the specimen, and just as a matter of course, they just checked that. So I've never had a biopsy at this point. Let me ask just before I forget, what was that person's name that you recommended?
Paul Corn, C-O-R-N. I'll send you his details afterwards.
Okay, that'd be great.
And he's at MD Anderson. The other thing is, if you've never had a biopsy, and you haven't had the Naxumin scan now, and how long ago did you get the Lupron?
April 12th.
Oh, so it's well over a month. I think most docs are going to say it would be really helpful to have an idea how much cancer you have. I mean, it could be, and I've seen this. I mean, I remember a guy back in 2008, 2009, who had one core of 4+4. And it can happen. I mean, we don't know whether we're dealing with a high tumor burden or a low tumor burden. And it seems to me that before we jump into treatment, if it were me, I'd want to try and figure out a little more about what my cancer looked like. You know, you're wondering about this node. I mean, that node could get biopsied if necessary, but we really don't know. We don't know if it's in your seminal vesicles. You know, even something as simple as a color Doppler ultrasound from somebody like Shinohara at UCSF, or you know, more some sort of decent screening, high-level screening, so that we know more. I would not feel comfortable if it were me. I would not feel comfortable jumping in without having more information. But let me throw it out to the guys.
Hi, Roy. It's Rich Jackson. I was
Hi.
diagnosed October of last year. I had 5 9s and an 8. But that was with the biopsy.
Mm-hmm.
What I did is I started Lupron and Casedex in December. I had high dose brachytherapy because they went in with a 3T MRI, identified the locations of interest, did internal radiation specifically to them, and then I did 25 external dose, 25 IMRT afterwards. With my numbers, I'd looked at proton, but in your case, we're not sure just how much is there. With mine, they found a fair amount. And what I looked at is energy on target. And with by doing high dose and IMRT follow-up, I could actually get more gray on the cancer cells, more energy on target than I could with proton or IMRT only. But like Rick said, right now, you know you have something, but definitely get some more information about what it is, how much is involved. I wouldn't be making doctor appointments for treatment. I'd be making doctor appointments for additional scans or biopsy or information gathering. But that's 9's nothing to sneeze at. My numbers, my PSA was 13, got their attention, but before the biopsy, it had dropped to 8.6. So it was still out of the normal range. That's my 2 cents.
No, thank you, Rich. I think that's very, very valuable. And the other thing I would say to you is the mere fact that you've gotten that Lupron shot, which on the one hand is very good because it sort of puts you in hold and gives you a little bit of time to make the right decision. On the other hand, it may distort the actual picture right now, although, you know, Lupron moves pretty, the impact of Lupron on the actual tumor takes some time. I mean, it should have an immediate impact on the PSA, but in your case, with such a low PSA, again, there's all kinds of abnormalities that could kick in. That's why I really feel that, you know, get yourself to a center of excellence with docs that have seen how to deal with hi-Gleason, low PSA men before. Anybody else? Who else would like to say something? Go ahead, please.
Roy, thank you. Roy, this is Len. I don't believe you mentioned whether or not you had a 3T MRI and a CT of your abdominal area. Did that happen?
I did. There's 2 things I want to mention. One is I did a CAT scan, and it went from a lower abdomen, I guess top of my legs, all the way up to my chest because I was having some back pains also. And all that wound up negative except from the operation I had done in March, the month before. They told me not to be active at all, lie in one spot so that that area could heal. where they had made an opening for to be able to go to the bathroom, and I developed 2 clots that were in my lungs. So right now I'm on blood thinners, and they said you really can't see if I'm, if the blood thinners, you supposedly your body takes them away by themselves, and they're afraid of not having any more blood clots, and that's what the blood thinner. I take 2 pills a day, then till the end of June. They say after a 3-month period, they could see if it's kind of shrunk and it's okay. Maybe I could stop taking these darn blood thinners. And that's the reason I'm also worried a bit about a biopsy, because I'm afraid, because nothing in me is clotting right now.
Right.
If they get things like don't get your teeth cleaned by someone who's aggressive. And the other thing I didn't mention was I did just a general blood test, which the folks in San Diego requested, and Dr. Rossi's team. And my PSA went down from the mid 3s or the low 3s down to 1.6, 1.5. It went down during these, I guess, from the Lupron shot.
Yeah.
It went down during this, well, it's not quite 2 months. June 12th will be 2 months.
And
it's been about six weeks so far.
And you're not taking any 5-alpha reductase drugs like finasteride or dutasteride, Avodart or Proscar?
No, the only drug I take is that one.
Okay. So
nothing else.
It's great that your PSA dropped. That's a really good sign, because it means that you are responding well. But even if you had, did you have an ultrasound on your prostate?
And a generalized bone scan for my whole body, and a CAT scan, which included the prostate area as well as all the way up to the top of my lungs, where they found those blood clots.
But you didn't have I mean, what I'm trying to get at is, you may not need a biopsy, but you might need a better idea of where exactly the cancer is around the prostate. If we know the cancer's 4+5 from a single sample, then, or a 5+4 after the review, then we know you're a 5+4. So they don't necessarily need more biopsies. But I think it would be helpful to know how much cancer there is, whether it's extruding at this point in time, whether it's got into the bed. I mean, all of these issues I think are going to be important in the sort of treatment that you decide, and certainly one possible option, as opposed to PBRT, would be the high-dose brachytherapy possibly accompanied by PBRT, or IMRT to the whole of the pelvic area. These are all discussions to have. My biggest concern is that when you go to these PBRT doctors, they don't talk to you about anything else because they want to sell you on their equipment. And it's a real conflict of interest. And so I'm not saying PBRT wouldn't be the best for you, or if you needed pelvic girdle radiation, the pelvic girdle radiation by PBRT might be the best option. But you're not really hearing about some of the other alternatives that might be available to you. And that's a concern to me.
Yeah.
Rick and Roy, this is Peter. Roy, are you the urologist you use? Is he at the University of Miami or a university setting, or just a small community setting?
The urologist was in Steamboat, so he was.
Steamboat, yeah, okay, yeah, we went through that. That's right. Yeah, Rick, do you know of any good urologists at the University of Miami or someplace in that area?
No, I mean,
top people?
No, we've always floundered in terms of South Florida as to to really reliable names. I will look and see, but the answer is I don't think I do. And most of the decent Florida urologists that we know of are further north. I mean, Paul Frito, have you heard any decent names down in the South Florida area?
Decent names from who?
The
For what?
urologists.
Oh, yeah. I have a very good one. But I can't remember his name right now. But I can look it up and then get back to you. I actually saw him in the year 2000 when I was visiting my mother and got first diagnosed with BPH, and then 15 years later, when I moved to Florida from Thailand, I found him again, and he's excellent.
Mm-hmm.
He's in the Palm Beach area, and I just can't remember his name off the top of my head, but he's very, very good.
Okay.
Rick, this is Peter again. This is Peter again. I was speaking to another guy, oddly enough, the same day, who's the father of a friend of my son's here in Maui, and he lives in Miami. He's going to see a Dr. Dipen, D-I-P-E-N, Parekh, P-A-R-E-K-H. I looked him up. He's the head of urology at the University of Miami. He came over from Houston. He was with MD Anderson. He had his training. He originally trained in India, but he had his training here at Memorial Sloan Kettering and someplace else in New York, another big outfit in New York, before he went to MD Anderson. So he seems to have great credentials, and he seems to be a very compassionate guy. I don't know him personally, though.
If it were me, I think I'd be heading straight to a center of excellence like MD Anderson, only because we're dealing with 5+4 disease. We're dealing with a disease that does not make much PSA, which means that prostate cells are already very unusual cells and may not respond to treatment in the way that prostate cells often respond to treatment. And I know that if they referred me to a urologist or radiation oncologist at MD Anderson, that I would be getting very, very good people. I mean, the overall experience, if you're willing to travel to Loma Linda or San Diego for treatment, going to Houston is a lot closer, and the overall quality of treatment, it's a much more holistic approach. I don't mean holistic in the sense of complementary medicine holistic, although that is an aspect. But what I mean is that you're getting all the disciplines in one place where they're all talking to each other and able to determine what is the best. And for me, I don't want to go to a urologist in Miami and a radiation oncologist in Southern California, and then a GU Med-Onc in Houston. Why not go to Houston, where it's such an outstanding facility, and they really take care of you? Everybody, I just spoke to somebody recently who was at Anderson, and they said, the place was great, the experience was great. And so I think if it were me and I could afford it and I was living in Southern Florida, I'd hop over to MD Anderson.
Yeah, Peter, by the way. Peter, did you say he's now in Miami?
Yes, this guy is, but I would, if he just needed an MRI or something like that, but I agree with Rick. I think, going to a center of excellence is probably good, but I think you're going to need somebody locally at some point, but I agree that you need to get more information about your disease.
Rick, I got that name. His name is Jerry Singer, Dr. Jerry Singer.
Okay. So, there's another name for you for a local guy, but again, I'd be I'd steer away from community practice.
He's in the Palm Beach area, in the Wellington area, which is you know, a little bit west of West Palm Beach.
Okay.
No,
Very good, very experienced, very good, and in contact with all the, you know, the other doctors, you know.
I just think I would. I mean, even if you had a Gleason 5+4 and a PSA of 40, I would be less concerned. But it's that low PSA combined with the high Gleason that, to me, just sets off red flags that I really want some very, very smart people on my team from the beginning.
Hi, it's Larry Fish. You know, one thing, I mean, I'm thinking a little further down the road. The Anderson or something, is that's going to be difficult if you keep going back there and come back and back and come back. What worked for me, although I didn't actually have to pull the trigger, was I saw the doctors that I really liked in let's just say Memorial Sloan Kettering, and as I planned to move or be local in a area upstate New York, I asked the doctor I like the best, like, who can you recommend that you can work with locally? And they gave me a list of 2 or 3 names, and I went to somebody that I liked. So I set up this longer-term relationship so that I could live upstate, but still periodically be in touch with my doctor from Sloan, who would communicate and had experience working with the local med-onc. So just to think like it's not just to go like to MD Anderson or somewhere else just for an opinion, but to go there to start to set up a relationship that might not require you going there every time. If you had somebody locally who could work with somebody or the team at MD Anderson, I have that in place, and it makes me feel very comfortable.
Right, and let me add on that score, Roy, that Paul Korn will do that. He did that for one of our guys who had a he passed earlier this year, Jim Cameron. He had a very strange disease. His disease was very regular, but it recurred in a very unusual form called spindle cell prostate cancer. And we referred him to Paul Korn, and Paul Korn worked with his local doc who was in Sarasota, right? Len, where was he? Somewhere. It was Venice. He was in Venice on the west.
In Venice.
But I think Larry Fish's point is well taken. I mean, get yourself over to one of the best institutions in the whole of the United States. Let them help you sort out exactly what disease you have, what sort of treatment, and then you can decide where you want to get that treatment, either at MD Anderson or they can recommend somebody locally.
Okay. So you're saying my San Diego versus Loma Linda decision was making life too simple?
Well, it may not be, but I think it's down the road. I think that, you know, it may turn out to be a simple decision, but as Rich said, and as I strongly feel, I really would want more information before I decided what I was going to do. I'd be comparing other options. I mean, have you discussed high-dose brachytherapy with anybody?
I did. There was a doctor in Manhattan, one of my son's friends, who had someone who worked with the radiation seeds, I guess. And we sent a copy of my CAT scan, and the way that the TERP was done, he said I would not be a candidate for that.
Okay. I mean, I would just want to hear more as to the reason why, because when the rods are put in, they're able to place them. They're usually able to place them in a way that they can stay away from sensitive areas. So
yeah, I think it was the cut that bothered him. It was not like uniformly urologist who did the operation said he made like a little tunnel, which is worked quite nicely for the urine to pass through. But he said the way that it was done made it very hard to use the brachial.
Okay. Well, again, I would want to be getting some really good opinions on that, and not sort of a friend of a friend, but I'd be wanting to talk to some top radiation oncologists that didn't have an axe to grind. And that is always a problem with PBRT because they got to pay for the equipment.
Right.
And so, that's why if we refer you to somebody like Paul Korn, he's going to have the experience of seeing this type of disease. He's going to be able to compare with you the different treatments, but he's not going to be the guy giving you the treatment.
Right.
And these guys don't care to the extent that you get treated somewhere other than MD Anderson. The doctors don't care there. I don't mean that in a flippant way, but there's no financial benefit for them.
Right.
What you have to be careful of with those centers is that they don't hustle you into a trial that you really don't belong in. That you do have to be careful of. But, they come back with trials, you'll come back and talk to us.
Right.
Roy, one of the things that I bumped into when I was selecting treatment was we've got a proton unit here in Hampton. It's a university across the river. I talked to the doctor that would be administering my treatment. My wife and I both walked out, looked at each other, and says, "Used car salesman." That is exactly. I've got a shiny hammer. It's a big hammer. It's beautiful. It's nice and shiny, and you look like a nail. And my hammer will fix your problem. That was the entire presentation.
Yeah, I ran into that. I have one about an hour away. Here I am looking to go across the country to California for the length of time Linda's done it, or the pencil with Dr. Rossi. And I have one about an hour away. And I called them and I just left my number, and the doctor called me back on a Sunday, and he was selling, and they have one unit up and running and another two units are coming up like over later in the summer. He was saying, well, we could put off your treatment till these units are up and functional. And then they had referred me to one of his colleagues. He says, oh, I'm much more experienced than her. I'll change your appointment to be with me instead of with her. And it was very used car salesman-like. And I just canceled my appointment, and I kind of wrote off the University of Miami as far as at least the proton therapy. They might have someone else very good that could give advice, but that was definitely a turn on. The same reaction that you did, that it was just a total turn off to dealing with this used car salesman trying to pay for his proton machines.
As Rick pointed out, I'm in Hampton. I was going to Hampton, Virginia. I live in Norfolk, Virginia. You went to one in Florida. We both had the same experience. We both came away with the same impression of a used car salesman.
Right.
I bet you they don't know each other.
Hi, it's Larry Fish again. One thing I just noticed as I'm listening to Rich talk, he's saying things like, when I was looking for collecting information for what treatment options I was going to take and I was going to decide, I think most of us in this group have kind of gotten to this point where we want to select and get the best possible advice from the best possible places. But in the end, that we're making decisions and we're participating in decision making. And nobody in general, if possible, is leading us, by the horns, and no one is. You find the doctor you like. Of course, they are more experienced and they know more, and you want to hear what they have to say. You can easily accept what they want to say, but you get this feeling that I'm the person that is going to be ultimately, responsible for the decisions that are made, and I want to be involved in those decisions and picking the best choices that I believe in, and Not that this doctor is saying, see that doctor, and that doctor is saying, do that, and that doctor is telling me. Just to think of that role of yourself as really being a strong part of this, because you really have a serious condition. It's a serious thing, and you should really, like, in my opinion, think of that role of yourself as being the center of that team, even if you got.
Yeah. As a thought with that, does it make sense? You know, I took a 3-month Lupron shot, and the 2-month spot I guess the 3-month spot, next one will be in the middle of July. Should I, while doing this fact finding and trying to talk to people and figure out the best treatment for myself, does it make sense? Because, you know, I read a whole bunch about Lupron from the UCSF site. Does it make sense to, and all it did was give me more questions. Some people say do the 1 month Lupron because the effects seem less.
Let me interrupt you, Roy, because we do need to move on. Because I want to
Sure.
get some other folks. We had, I think it was last week, but if you go to our website and look under recorded calls, we had a whole discussion about the 1 month versus the 3 month versus the 6 month, and you know, which tend to work better, and which are more effective. And it's a discussion worth listening to, and you can find it on that recording. And the bottom line was that the shorter shots probably are a little more effective than the longer shots. I was also going to ask you if you'd read the hormone therapy pamphlet. From UCSF. It sounds like you have, because that's a good primer on hormone therapy. But what, you know, just to wrap up, I've got your email address from Peter. We'll add you to the distribution. We meet every week. We meet either on a Monday or a Tuesday. The next meeting will be next Monday. Just keep coming back. Keep asking us questions. And I know, again, as I don't want to sound like a broken record, if it were me, I'd be making a beeline for MD Anderson, and I'd probably kick off with somebody like Paul Korn, only because of the nature of my disease.
Hello?
Rick,
Yeah.
you broke up. We missed everything you just said.
Oh, really?
Yeah.
Yeah, after the word Anderson, that's when we lost you.
Oh, I was
Essentially, get a medical oncologist from MD.
right. I say get over to MD Anderson, and get onto Paul Korn's books as quickly as you can, based on the nature of your disease. But don't be surprised if they want to do, you know, they've got some fact finding to do first. Okay.
Okay. Good advice. I appreciate it tremendously.
Pleasure. So let's resume with Dan Louie.
Hi, Rick.
Hi.
Hi. Well, I guess what I'm going to start off by saying is I don't know what options there are left for me. My PSA has been going up a lot. When I took the test in April, last month when I took a test, it was 36. But the one test last Friday has not been posted yet. And I think I'm on my 3rd day right now since the blood draw, so it should be posted soon. Okay. I've taken some body scans that shows increased progression. I went through some Provenge treatment. I took a Garden 360 blood draw. Haven't discussed that yet with the oncologist. Don't know what they can make of it. I don't know. I mean, to read it and understand it is beyond my comprehension. I went for radiation back in January. I had an appointment scheduled earlier this month, but because of the strike, it's been canceled and rescheduled till, well, essentially till tomorrow. My question is there, looks like the options right now are either trials or Sofigo. So I don't know what Dr. Argowal has in mind for me, but he did mention maybe some trials that I signed some forms recently, haven't turned them in, but I'm planning to meet him tomorrow morning in conjunction with getting some periodic injections of Lupron and Exgeva.
Mm-hmm.
I've been experiencing some pains in the last 2-3 weeks, a very annoying pain. It almost immobilized me a lot, and I tolerate it by either tolerating it, not taking any ibuprofen, but I'm hesitant to go into the hydrocodone, which was prescribed to me back in December when I had intense hip pain prior to getting the radiation treatment. So one of the questions I had is it, with the Provenge treatment, does it take time overall, or maybe I'm not affected by the administration of the Provenge treatment? And the Garden 360, how can I get the oncologist to kind of read it to me, or have someone knowledgeable in that to kind of guide me? Well, what do I have in there that kind of reveals my conditions or the origins of my condition?
So a couple of questions. I'm assuming that it was Dr. Agarwal that prescribed the Provenge, is that right?
Yes, he did.
And did he not talk to you about the treatment and what you should anticipate in terms of results from the Provenge?
Kind of. He sort of said it'll stabilize my condition, but he didn't indicate to me that there'll be guaranteed reduction of my PSA.
Well, I think that's because there is no guarantee. You know, Provenge, not only doesn't it reduce it, it may continue to increase, but we know that it seems to be that the Provenge gives you greater overall survival. That's always been the case with it. And the earlier you get it, the better it is. So you should have no expectations of seeing, and it should have been made clear, don't have any expectations of seeing a response in your PSA to the Provenge. Doesn't mean to say it's not working. And that's that's really something important to set. You know, I wish these doctors would set up the right expectations when they administer the Provenge. I mean, I'm all in favor of Provenge, but people need to understand that they may not see any benefit, actually see a benefit. And whose idea was the Garden 360? Was that Dr. Agarwal?
Yes, it was. And
was there a reason why he preferred that to taking a solid tumor sample?
There's no rhyme or reason to that. It just says, hold on here. My source says, can you repeat that question here?
Why did Dr. Agarwal prefer Garden 360 to either doing it in-house, doing an analysis in-house at UCSF, or sending you to sending it to Foundation Medicine?
Hi, Rick. This is
Hi, May.
What were you guys talking about?
Garden 360. We haven't really discussed it with Dr. Agarwal. The results.
No, he did speak to you about it.
Well, it didn't.
It just didn't make any sense because I don't think he told us. He just gave us the written report and says we can look at it, but I have not attempted to look at it because it's a very, very long report, and if he doesn't know what to say about it, I didn't want to waste my time even looking at it. You know, I really don't understand why we got the report. But one of the reasons why he didn't do a bone biopsy at the time was because Dan was in a lot of pain, and he was already scheduled to have radiation to the area where there was a possible biopsy done, and he said he didn't want him to suffer anymore because the radiation was already scheduled.
Okay. So, I mean, so that I'm trying to understand why he chose the liquid biopsy. He may have chosen Guardant over the Foundation Medicine liquid biopsy because I think Guardant has a bigger panel. But the bottom line is, and he may talk to you about it tomorrow, have you actually met with him since you got the results of the Guardant?
Yes, we have. He didn't have, like I said, he didn't have too much to say about it.
Okay. Did he tell you? Did he tell you if there were any actionable mutations?
You know, he didn't say anything, but before we even saw at the nurse practitioner, the nurse sort of briefly looked at it and told us that according to the report, there were lots of drugs that could be used. That there were a lot of mutations. When we met with Dr. Agarwal, he just says, yeah, there's lots of mutations, and he says, yes, this is very typical of men with advanced metastatic cancer. That's all I remember him saying.
I think what you've got to ask him specifically tomorrow are a couple of things. One, are there any actionable mutations? That is the phrase to use. Are there any actionable mutations? And if so, what are they?
Well, here's the thing. Tomorrow, actually our appointment was for today, and I'm really worried about why he canceled it. I think he canceled it because Dan got a blood test last Friday, and Friday afternoon he decided not to meet us today. He's going to meet us tomorrow. The reason was there wasn't time today, and I have a feeling it's going to be really bad because this appointment was made 3 months ago.
Mate, don't project.
Yeah.
Don't project. If he's telling you that there are lots of drugs and there are trials, there's probably a lot of options. I mean, I can think of 3 or 4 options right away. And there are probably lots of options. So this
well,
this is May,
to do another phone.
I'll tell you what, I'll make a deal with you. You let me speak and then I'll let you speak. Because I'm in the middle of a thought, okay? And you can take some notes down so you know what to talk to him about.
I'm writing it down.
Good. Okay, so you've got to find out if there are any actionable mutations. You've got to ask him what might be actionable and what might not be actionable. You've got to ask him if there are any trials for any of the mutations that you have. You can ask him about some other alternatives. Have you, I cannot remember, but you have not done chemotherapy, is that right?
Yes, correct.
So, you know, chemotherapy is an option that if you want to prolong your life, you're going to have to consider.
We haven't broached the subject with them yet.
Well, I think you need to. You've got to put that on the list with a big question mark, an exclamation mark about chemotherapy. You know, maybe chemotherapy is the right course right now. This is what I'm saying to you. This is what I'm saying to you, May. There are a lot of options. Apalutamide, which is the new drug that just got approved, may be an option, may work when Zytiga doesn't work anymore. You know, so there are if Zytiga and don't work, it's possible that those could work, but I don't think that you should be projecting in your mind that he put it off and and there's nothing that can be done, and this is the end of the road. Believe me, it's not the end of the road. And we've got men. I mean, Eric Bookbinder just joined us, and Eric's been through a lot more treatments. Xofigo, I'm just not sure about Xofigo. I'm not sure about Xofigo. I think that you can't do Xofigo and chemotherapy together, and I think you're going to get much better results. If it were me, I'd be looking to do chemotherapy probably initially with docetaxel before Xofigo, because it has better results. Guys, chip in here and give Dan some hope, given where he is at this point in time.
Can I tell you one more thing? Hello?
Go ahead.
Actually, tomorrow, he's planning to enroll Dan in some kind of trial. I'm not sure what it is, but I guess there's another lesion that he could do a bone biopsy on. But I don't understand why it's called a trial.
Or study.
Oh, yeah, some kind of study, but they're thinking of doing a bone biopsy.
Okay, but what is that trial for?
Oh, I don't know.
Wasn't really explained at all.
Okay, but did you sign the papers?
Yes, he did. But we're going to talk about it tomorrow.
Okay, don't sign the papers until you know what the trial is for.
Well, it's to do a bone biopsy.
And we'll help you. You know that. But I can't. It's hard for us to come in and work with you if you tell us, well, but we're entering a trial tomorrow. What is the trial? And you can't even tell us what the trial is, love. We can tell you that there's a lot of options. Len, bail me out.
Yeah, I don't know Dan's history very well, what he's already had, what his Gleason was, what his staging, all that sort of thing. But yes, of course, there's always new effective treatments on the horizon in advanced clinical trials. You talked about the mutations, but we don't know if you have actionable mutations. If you do, they have drugs already approved for certain actionable mutations. Certainly don't give up hope. And also don't, as Rick said, don't enter any trial if you don't know what it's all about.
Right, I agree.
Well, they should have gotten copies of anything they signed.
Yes, we do have it. It has some. They're going to do a bone biopsy. But I just didn't understand why it's called a trial. I thought normally anybody could do a bone biopsy without having to be as part of a trial.
Yeah, but the bone.
I would imagine that
for a reason.
The bone. Yeah, they're doing the bone biopsy to find out what mutations you have, and then they can put you on a trial.
Understand.
Oh, maybe that's what it is.
But the papers are going to tell you what the drug is that they're doing the bone biopsy for. That's where we're struggling. Don't sign stuff without asking for some advice or going through with the trial coordinator or talking to one of us or bringing it onto this call. There's enough knowledge here. We can all help you, but they're doing a bone biopsy, as Eric correctly says, because they're looking for a mutation for a particular drug, and the papers they gave you are going to indicate, most likely, I would guess, what that drug is. Wouldn't you say, Eric? You've signed enough of those.
Yeah, they may not. They may just, be that they signed the approval of the bone biopsy.
Don't they, when you sign the bone biopsy, don't they tell you what it's for?
No, I mean, when I had my foundation study, I just had the foundation study. It wasn't for something. It was to see what mutations I had.
Right, but you knew that it was getting sent down to to Foundation Medicine for analysis, and you missed.
Right, but there was nothing targeted. There, they weren't targeting anything. They were just looking to see what could be targeted.
We just had that. You missed that part of the discussion that Agarwal decided to do a Garden 360 study because he didn't want to target the bone because it was too sensitive at the time. I mean, it is possible, Eric's right, that they're just doing this to do another analysis. And it's not a trial. It might be just an analysis.
It says, it's called the PROMOTE study. Dan just found the paperwork. It's called the PROMOTE study, identifying predictive markers of response, precision oncology and molecular targeting in advanced prostate cancer. Yeah. Identifying predictive markers of response is called the PROMOTE study.
Right.
And Dr. Agarwal is the, I guess he's the main doctor for it.
Yeah, he's the PI. I can't look at it whilst I'm online. Len, maybe you can just check the PROMOTE. But I think what they're doing is it's a study to try and find to try and match drugs to mutations, which essentially is what we want to be doing right now. And clearly the Garden study wasn't good enough, or it wasn't clear enough. I don't know why. Well, we do know why they did the liquid biopsy. It was because that they didn't want to do a solid biopsy at the time. Now they're doing the solid biopsy, and I guess hoping to come up with a treatment for you. I mean, that's essentially what I believe they're doing.
Yeah, probably that's what it is. That's what we're going to be.
But, ask him these questions. Ask him about how long will it take for you to get the results? How's Dan going to respond during that time? If it's going to take a month to 2 months to get the response, how are we going to hold Dan over? What about chemotherapy? What about some of the new drugs that have come out recently? Would that be an option?
Okay.
Anybody else want to chip in here?
Rick, I didn't see anything on clinicaltrials.gov with a trial called PROMOTE.
Okay. Did you? All right. I'll look. I know I've seen stuff on it. I've just got to look. I think
the sponsor is Prostate Cancer Foundation. Principal investigator is Eric Small.
Yeah.
Okay.
Yeah, I've definitely seen stuff on it. So it's a solid trial. You might look under UCSF then and see what that yields. But have you heard anything about this from Agarwal, Eric? The PROMOTE study? No. All right. Well, I think there's a couple of things here, and these are good lessons for everybody. Be very clear with your doctor why you're doing these studies and why you're doing a procedure. Don't just sign a paper and go in and then say, well, I don't know, this could be the end. And it's not going to be the end if they want to do a study. Right, Eric? Isn't that right?
I hope so.
Mr. Bookbinder, so. Isn't that right?
Yeah.
It's not the end if they're doing a study, correct? Right.
Yeah, and if somebody tells you it's the end, go ask someone else.
Thank you. There's my man. There's my man. So, don't be reading stuff into it, May. There's lots of stuff here, not the least of which is chemotherapy. Not the most pleasant option, but can do an awful lot. And if, and I know you've been trying to avoid it, but if you want to keep your husband around, it may be something that you've really got to look at. And it could be effective for a very long time. So be talking that. Anyway, we're going to move on because I really want to get around everybody. I want to give Neville some time and Gary, and I definitely want to find out. We all want to hear from Eric as to what happened last week, and Jake too. So I'm going to go.
Rick, we also have somebody that's on the phone that called in a few minutes ago.
Yeah. Would they like to identify? Somebody on the telephone who just called in recently, would you like to identify?
Is that Sylvester, maybe?
Okay, no worries.
Okay.
If it's somebody that we don't know or somebody who's called back, that's fine. And feel free to listen, whoever it is, and you are very welcome. You're always welcome. Just to listen in. Neville, tell us a little bit about your situation and give us a quick rundown on what's going on in Australia.
Well, thanks, Rick. But before I do, I'd just like to say to that last couple that you had on there that a lot of people respond really, really well to docetaxel, and some people have issues with it. But then they have cabazitaxel as well, Jevtana. So, and many men in Australia find Jevtana, cabazitaxel, a lot easier to tolerate and works really well. So there's not just the one chemotherapy either. So there's more than one. When I was in Melbourne, and to Roy, he was asking. I think he asked about 90 days versus 1 month injections for Lupron. Well, as you know, I have a Eligard needle, which is like a Lupron, the ADT drug, every 28 days. So I do. Because when I was having the 3 monthly injection, my PSA or more so my testosterone used to bounce around more. But when I have it every 28 days, I don't. I have a lesser of that worry. So I do. So I opt to have Eligard every 28 days, and I've been doing that since April 2011. Well, not every 28 days since April, but I've been on Eligard since 2011. But for about the last 3 years, I've been on it every 28 days. So I have.
Mm-hmm.
So when we were in Melbourne last week, we got a look through the research centre at Peter Mac, and they're on the phase 2 lutetium trial, as you're aware. But they also were trying to grow prostate cancer cells in a dish, which is extremely, extremely hard to do, apparently. And they're doing that and to treat difficult to treat prostate cancers, and they're in collaboration with Johns Hopkins, and I think it's Seattle is the third one. But yeah, so I just thought that might be of some interest. Jim's off LA in September. I may not be. I had a pacemaker fitted earlier in the year.
Uh-huh.
So I did. So I take Eligard every 28 days. I have a needle for Eligard every 28 days to keep me alive to die of something else. And I've got a. It's also found I've got a bicuspid aortic valve, and that may have to be replaced in the next few months. But I'm undergoing more tests at the moment to find out exactly whether that's going to be urgent. They can just put a stent into that, or see what the treatment might be, short term, longer term.
What about Neville? What about the surfing? Aren't we doing any surfing in between, or?
Oh, no, I don't think so.
Oh, okay. I'm just I'm traveling really well. Apart from just the pacemaker worked well. I did have a big issue with antibiotics after I had the pacemaker fitted. Right.
A week after I had the pacemaker fitted, and that was a bit of a drama. I'd had 10 days in hospital as a reaction to the antibiotics. But anyway,
are you doing any better with your incontinence issues?
I've got a sling with that, so yeah, no, that's fine.
Good. Okay.
Yeah, I got an advanced male sling, and yeah.
Okay.
So,
good.
Yeah, no, that works well.
Good. Okay. It's so nice to have an Aussie back on the call again. We haven't heard from Jim. We really miss Paul because he was with us regularly, and and we lost him last year. But it's lovely to hear your voice, and we welcome you anytime.
Yeah, no, I appreciate that. Yeah, no, you break up a bit there, Rick, but yeah, we miss Paul too.
Yeah.
So we do. Yeah.
And if you speak to Jim, tell him we all send our very best to him, and hopefully we'll.
Yeah, no, I speak to Jim every day nearly.
Okay. You tell him Peter Kafka's been training for the last year so we can race him on the scooter. Isn't that true, Peter?
But I'll tell him that.
You tell him. Is Peter still with us or not? Are you still with us, Peter? Oh, I wouldn't take his name in vain if I thought he was off the call, but I guess he's not on the call. He's gonna have to listen to the recording. Okay. Well,
No, I'm on the call. I just had to switch phones because I'm driving now.
Oh, okay.
I'm the one that called in later because I had to switch phones.
I see.
Yep. Now we know who caller rate is.
Right. All right, Peter. Well, as we said, we're getting feedback. As we said, or in training on his scooter. So, all right, enough of this frivolity. We have to move on to more serious issues like Jake's blood test. Where are you, Jake? Are you with us?
Yeah, I'm chewing on an onion ring. Sorry. I'll just take a moment. My PSA is the same, 0.7. My testosterone went from 21 to 26 in 1 month, which I don't quite understand, but it might be because I'm at the third month of my 4-month Lupron shot too. I don't know. Other than that, everything was normal. My glucose was a little high, but I've been eating a lot of junk lately, so it's not as to be expected, I guess. I don't want to take away from anybody else. I know you want to talk to Eric and a couple of the other guys.
Any particular questions or thoughts about? I mean, this moving around of testosterone at the end of the period. We have talked about that a fair amount. Anybody got any thoughts on that, or why Jake might have seen a small rise? I know testosterone is a very variable factor when you try to measure it. It's not
right.
Not that constant. Anybody have any thoughts on that?
Well, from what I heard, Jake, it sounded like you were on a 4-month shot. You should probably drop it down to 3 months, and you probably have better control, like we talked about last week, I think.
Yeah.
Yeah, I've been on a 4-month shot from the very beginning, but this is the first time they actually the phlebotomist keeps screwing up, and so this time she took 2 testosterones in every 30 days, which normally doesn't happen. So it may have been fluctuating all along. I don't know.
Right.
So it's still pretty low. 26 is. I'm happy with that.
Right.
Yeah. And congratulations on the stable PSA. That's good too.
That's very.
Thank you.
And think about the 90-day shot, because it's not that different, and it may be a little more effective. I mean, I did 90-day shots for the 28 months I was on there. So and yes, I do know that 3 doesn't go into 28 evenly, but 4 does. But I promise you, I did do 90-day shots. Okay, let's talk to Gary, and then we'll talk to Eric. Gary.
Well, I feel almost embarrassed because I have such a low PSA, you know, after surgery and everything, but the urologist has sent me to a radiation oncologist, and so I'm supposed to meet him this week, and all I had was, you know, I wanted to know what kind of questions, what kind of things should I talk to him about. I guess that was it.
And where exactly? So your surgery was back in November of 16, is that right?
Yes, yes.
Okay. And your PSA has been less than 0.1 until when?
Well, you know, even, well, in the last 9 months, it went 0.04, 0.04, and then the last time it was 0.05. So it just didn't seem to bother me too much. But I think the idea was to meet with this radiation oncologist to establish the connection and then see where we go from there.
And when, just give me some time frames. When was the first 0.04?
That would have been 9 months ago.
9 months ago. So like September of last year, or August.
Yeah, yeah, I would say that. Yeah.
Okay. And so you're just seeing very small increases, and so the
Yeah, very small.
And the question is, what I mean, I can tell you that, you know, most docs won't even start to consider intervention until you get to 0.075. And usually, if you've gotten there quickly, but you know, you may not get to 0.075 until you're more than 2 years out, quite easily. And so then they'll say, well, you're not moving that quickly, so hang in with it. And, you know, at some point, do you have a GU Med-Onc on your team yet, Gary, or not?
No, there's no GU Med-Oncs in Spokane, so I would have to go to Seattle.
Right.
And I don't know anybody there, so I'd have to find out from people.
I can give you, no problem. We can give you names for Seattle when you're ready.
Okay. And that's the other issue. Since my PSA, when am I ready for something like that? When am I ready to go to a medical oncologist or a medical oncologist? I mean,
well, I would say it's a GU medical oncologist that you would want to talk to. And I would say that any time, since it seems that you have recurrent disease, it's good to get to know them and to have them on your team and to work with them to pick the right radiation oncologist, because, you know, it's somewhat a similar issue to Roy, is that these radiation oncologists in community settings, sometimes they want to pull the trigger too quickly because they earn money. I mean, I hate to say it, but you've got to be aware of it. And it'll be interesting to see what, if you go in to see this radonc next week and he says, "Oh, I don't need to see you for another 2 years," or if he says to you, "Oh, we need to do treatment next week," or if he says to you, "Yeah, I would do treatment as soon as we get to 0.075," all of those have issues around them. I mean, what you probably want to hear a doc say to you right now is, let's keep monitoring you, get tested more regularly, let's watch what's going on, watch where the velocity is. But the other thing I want to say for everybody on this call is, if you've got recurrent disease, this call is the right call and it's for you, and don't ever be embarrassed to bring up your recurring disease. Whether your PSA has gone from 0.04 to 0.05 or whether it's gone from 5 to 10. It's all important, and we've got time for you. So, so don't be embarrassed about talking about this. Let me throw it open. What advice does anybody who's been through this recurring situation after a radical prostatectomy, what advice do you have for Gary? Jesus. Like pulling.
Well, I don't like the idea of initiating radiation when you don't know where the lesions are. So I would wait. I would think if it were me, I would wait until my PSA was high enough that the most sensitive scan could pick up something. Otherwise, you're just shooting in the dark, in my opinion.
Yeah, it's a very good point.
Yeah, it's Larry. I'd want to understand, why do you want to do the radiation? What are you after? What's the point? I mean, if you can avoid it, if it's not necessary for something, what is it they're trying to accomplish by the radiation, other than maybe that's the pattern that the guy uses? I remember I denied when I went to Dana-Farber, the oncologist asked me, or the med-onc asked me, why does your doctor want to give you Xgeva and radiation when it's, well, in my case it was going to be palliative, but why do you want to just do that if you're not in pain? If there's not something specific that they're after, is it like a general idea? Just take some radiation, maybe it'll help you. It's confusing me.
Well, in a situation like this, scans can't pick anything up. So I always thought that it's the salvage radiation concept is just to try to, I don't know, hit the pelvic girdle and see if that just covered it, you know, since nothing can actually pick it up on a scan. So you are shooting in the dark, but it just, I don't know, is that a good idea or not? I don't know.
What was your post-op PSA?
Say that again?
What was your post-op PSA? Yeah, radical prostatectomy.
Yeah, it was 0.01.
But your post-op Gleason was a 4+4, correct?
Yes. Yes.
So go ahead,
Gary. This is Peter, and we've had this discussion before, and I think you and I have kind of diametrically opposed ideas. I mean, my idea and what I've done is I try to buy as much time as I can between treatments. Let things go until the point where I really need to do it, and it will be effective. I think from what I hear sometimes, you seem to want to hit things right away and try to get rid of things right away, but it might not be the most effective way to treat things. You know, if I was in your situation, I'd get as much mileage as I can between radiation between surgery and radiation. And if you can go 2 years, great. You know, because all these treatments come with a downside. You want to put that off if you can.
Okay.
I had a thought on that, and that is that since your PSA is very low, you might be able to do some radiation, but where the dosage is not very high. Therefore, you'd have a very low or almost no risk at all of damaging any of your regular organs. And then you've got a sort of a free shot at a cure.
Oh, I didn't realize that the radiation can actually be set lower so it doesn't affect you as much.
You can tell. Yeah, the oncologist, the radiation oncologist can do 75 gray, or you can do 65 gray, or you can do 50. And so you can do a low dosage so that there's almost no chance that you could hurt your bladder or your colon or anything like that. And then you've got like a free shot at a cure. And let me tell you, as someone who's dealing with side effects of Lupron after 2.5 years, getting a cure is really something that would be very nice for you.
Let me ask you, Gary, Paul. I mean, are you aware of any studies that have been done for salvage radiation with lower dosages?
Me? Are you talking to me, Paul?
Yes.
No, I have. I don't study the literature. I'm just saying that since you have a low level there, 0.01. I mean, the downside to radiation is that you may cause damage to some of your other organs. But if you can eliminate that possibility by doing a low dosage, you might get lucky and kill all the remaining cancer if there is any. Well, if whatever is there, and then with no risk.
Yeah, but I mean, just throwing that out without knowing whether it's effective concerns me a little bit. I mean, there are
right. There's no evidence. There's no evidence that that is a an effective strategy. It's just a matter of common sense.
There's no evidence that Paul's aware of, but somebody like Alan Edel is going to know whether there have been any low dosage trials on salvage radiation. And so what I would recommend you do, Gary, is to go into Google and first of all look at low dose salvage radiation on Mike Scott's site, Prostate Cancer International, or whatever it's what's it called, you guys? Prostate Cancer Information Network.
The new prostate cancer info link.
New prostate cancer info link. Have you ever used that site, Gary?
I have been there. Yeah.
Okay.
Yeah.
Go to that site, and in the search box, put in low dose salvage radiation and see if anything comes up.
Okay, will do.
Secondly, go to Alan Edel's blog, and I can send that to you afterwards. I can't remember what it's called off the top of my head. But Alan Edel has his own site. And Alan is a layman, but he's incredibly knowledgeable about radiation. And if anybody knows about low dosage salvage, it will be him. And if you don't find anything, let me know, and you and I can write to him, and he'll respond.
Okay, great.
Okay.
What's his name, Rick? What's his name?
Alan, Allen, and the last name is Edel, Edel.
Is that the same? Is that Tall Allen on one of the websites?
Yes, that's Tall Allen. That's the same person.
Yeah, he's quite knowledgeable guy.
So if you're on one of those websites, you can ask him. If you're on Healing Well, you can post the question. Anybody know anything about low dose salvage radiation? And guaranteed you'll get a really good answer from Alan. He's a very good guy. Let's see. I mean, I think that's what I would do. And I do understand it's unlikely at such low levels that anything is going to show up in the scan. But I'm not in if it's for me. So that's what I would suggest. But just keep talking to us. Come back. Let us know what you find. If you need help getting to Alan, we can take care of that. But get a little more information. And I do agree with Larry. I mean, just to see a radiation oncologist for the sake of it, when you're not ready, I don't know. I'm not sure why you would want to do that, but that's,
Just to get the information. I just want to get the information and know, just kind of get the game plan going.
Okay.
Gary, I'd like to second what Rick had stated about going to Seattle and getting in touch with someone at the University of Washington.
Yeah, I don't know anybody there, obviously.
I
So
can help you. I mean, I can put you directly in touch with a radiation oncologist who knows a lot about prostate cancer. She was mentored by Oliver Sartor, and I'd be happy to put you. She's a personal friend. Her mother is a friend of mine. I've helped her. Sorry, Ken?
No, I was just saying that I didn't want Gary to minimize PSA. I mean, there's no prostate, but a rise is a rise. So I would definitely go see someone in Seattle, get a your oncologist on staff, more direction in regard to whether or not radiation is where you go.
Right. Right. So, but let me know if you want to do that, and we can make the connections for you.
thank you so much. I really appreciate it.
Right.
This is Jake. Would Lupron be an option for Gary? Just to kind of keep the PSA at bay instead of shooting in the dark with radiation, because that's really what you're going to do if it's so, the PSA is so small, you're not going to have any nothing's going to show up on the scans.
Well, the question is when to start taking Lupron, when to start treatment is the $64,000 question. If and when Gary starts treatment, one would hope that they're going to put him on Lupron to make the treatment more effective. But the question is, when do you start that treatment? A discussion with a radiation oncologist is good. Getting a GU med-onc on your team is a good thing to do, and we can get your names for that too. It's a similar discussion to what we already had today. Somebody without an axe to grind. Anyway, guys, we're running out of time, and we all want to touch base with Eric and find out what happened with Agarwal last Thursday and what's going on. So we're going to move along. Anybody else want to say anything else to Gary before we go to Eric? Okay, Mr. B, the floor is yours. Tell us what's going on.
Well, I think I told you that the group that wanted to do radiation decided that for the review they didn't want to do radiation. So I contacted Agarwal immediately, and he wanted to proceed with screening as soon as possible. So he had me go to UCSF emergency. He said that was the best way to get admitted to the hospital. And they started doing scans, and they did a scan and did another scan and did another scan. And I was kind of left in the dark. I kept asking, what's going on? What are we looking for? They decided that they found blood clots in my lungs. So they're worried about PE. And so they installed a filter. So I have a nice new hole in my neck here where they put the clot filter in. And on Friday they're going to do, they also found that L3 is compressed. So they're worried about that. They said it's very critical. So I'm going in for surgery to have that fused. There are three things that they listed that they're going to do. And the three things are posterior spine fusion, 1 to 3 segments, lumbar or lumbar sacral. The other two are just methods of following what they're doing. They have these, it's called spine stealth navigation and O-arm fluoroscopy. And what that allows them to do is to get a microscopic view of what they're actually seeing in the spine as they do it, and it allows them to set the screws. It sets in a whole alignment mask up that shows where the screws go, so they can watch as they put them in and align them properly. So looks to me like, and again, you know, I haven't talked to the doctor himself yet, but it looks to me like they're not going to do anything with the thoracic spine. They're only going to do this with the lumbar spine. Now, the thoracic spine is where I have the pain. I'm definitely having problems with the lumbar spine because my gait now is not right. I have trouble walking. So I think it is important that they deal with that, but I'm just curious as to, you know, as I say, I have had a hard time getting answers. I did right before they released me from the hospital on Sunday. The four of the doctors, not including the one who's going to do the surgery, came in to talk to me about it. But I haven't seen what their plan was yet. They just said surgery was going to be scheduled. So the actual plan of what they're going to do didn't come out until today. So I've been having lots of questions. The reason that I was late getting on the call was that I was doing my registration and I met with the anesthesiology department and they took some blood and did some other odds and ends, mostly history, and you know, preliminary to the surgery. Dr. Agarwal wants to start the trial, but they have to recover from the back surgery first. So, and that's unclear as to how long that will be, and where, you know, whether I'm going to do that recovery at home or in a rehab facility. They haven't made that clear yet. The implication is that I will come home, as far as I've been able to determine. So, you know, as soon after that as Agarwal feels that it won't kill me, they'll start the trial.
Which trial? ES414?
I don't know. So I have some paperwork on it that I need to read through again to see what it is. It might be the ES414. We had talked about that, but he didn't make it clear as to whether that was what I was going to be on or not.
So in other words, he has a trial for you to consider. You're not sure what that trial is, but you're not really eligible to start it until you recover from the surgery. Is that right?
That's correct. Yes.
And what about care for you and care for Gail? I mean, how are you going to manage this?
Oh, unfortunately, my stepson is visiting his father right now in Cleveland, who has lung cancer. So he's not even here to help us until the 8th. But you know, I do live with a dozen people, so there is support here.
Okay.
As well as there's a person who helps Gail out 3 days a week, and she's going to fill in more time.
Okay. And they feel comfortable that the bone, the vertebrae above and below, or whatever's below L1, are solid enough that they can anchor some hardware.
That's what they feel now. You know, who knows when they get in there if they'll find different. But as I said, they did many scans, and I think that that was part of what they were looking for.
You sound way better. How do you feel?
I feel pretty good. I've been having a lot of problems with throwing up, and I don't know what's causing that. I've been taking more compazine to deal with it. Yeah. And my back does hurt. It's right at T2. And so I have to take additional narcotics to deal with that, opiates. And today I feel pretty good.
Good. So Eric, we have a new guy on the call who was on earlier, and I just would like you to give him your 2 cents. Diagnosed with a Gleason 9 and a PSA of 3. And he's wondering what to do. Now, didn't you, as I recall, have a very low PSA and a high Gleason?
Yeah, it wasn't 3. It was 5.6 when I was diagnosed. But that's still pretty low. By the way, my PSA is 82 now.
82?
Yeah.
Okay.
So that's going up. But yeah, I mean, as we've said, there are just some people that don't produce as PSA. This is far and away the highest mine has ever been. It was hanging down around in the 20s for a long time, and then it shot up to 60 and now 80. And so there's obviously a lot of activity going on. I think it's urgent for me to get on some chemo to deal with it. It was staying pretty steady when I was on the Jevtana, but then it started, the side effects started getting too bad. I had to stop that. And, I'm hoping that this, whatever it is, will stop the growth. The L3, they're planning on scraping the cancer out of that one as part of the procedure. I thought they were going to do more in the thoracic spine, but there's no evidence that they are planning that. I'm going to be talking to several of the doctors tomorrow, and I hope to get more answers.
Let me just throw it open for a couple of minutes, and then we'll close out. Would anybody on the call like to talk to Eric?
Yeah, Eric, this is Jake. I'm just glad that you got some more options available to you. They don't sound like they're much fun, but at least you have options. So, many of us last week were very concerned about you, just the way you were, your emotional state, and we were very concerned. And I, for one, didn't know what to say to you, but we were all feeling for you. And now at least we feel like there's some hope for you. So good luck to you, buddy.
Well, thank you.
Yeah, Alex, this is Peter.
Go ahead.
Did they give you any indication how long you might be in the hospital with this kind of surgery?
They said at least a couple days.
Couple of days. Amazing.
Yeah,
Okay.
no, they were very optimistic about when they could send me home.
Okay, well, we're thinking about you, and anything we can do, you let us know. If you need any kind of support in any way, let us know.
Well, thanks.
Eric, this is Len. I don't know if you were on the call several weeks ago when Bill Burhans was talking about an intrathecal opiate pump. He said
Right.
it changed life. I wonder if that's something, if you're interested, if that's something you can talk to your doctor about doing while they're doing the back surgery.
That's a good idea. So far, the relative dosage of morphine that I'm on is still fairly low. I take 60 milligrams in the morning and 30 at night, and usually that's sufficient. One of the problems I've been having is that when I'm taking the pills, it has caused me to throw up, and then I don't know how much medicine I'm actually getting, and I don't want to double up, so I just don't take it again. But I'm going to try and control that a little better. Take the compensine, before I take the pills, and see if that is okay. I was taking Zofran, and they told me not to take Zofran, that it was contraindicated in the study.
I think Glenn's idea is a very good one. 2 goals.
You're an easy marker, Jake.
I know. But yeah, I mean, while you're already going to be out and under, might as well, it's a thought. It's a very, at least worth asking about.
Did you did you touch base with BJ? Did you touch base with BJ?
Yeah, I did.
Okay, so
Yeah, I have a full call with him coming up. Not till next week, but I did talk to him. He called me directly, and we talked a little bit.
Fantastic. Fantastic.
I've also I saw my shrink this morning, and so got some help there.
Fantastic. You know, he would be a good person to, if you want to go through the intrathecal pain pump issues, he's probably the doctor that you've got to, you know, that can initiate that.
Right.
Because that's his, you know, he's the
one of the problems is that, you know, I won't know what the pain level will be after the back surgery until then. So,
right.
You know, if the pain level is not
right
sufficient, then you know, it would be it wouldn't be useful to have the pump. So.
Okay. Anybody else like to chat with Eric? I mean, we're all thinking about you. Friday, I'll make a note to try and call you on Saturday. And hopefully this will go very well. We're all thinking about you.
I'm hopeful.
We are too. Okay, guys, don't forget that tomorrow night there is an inner conversation call. Oh, is it Theisberg that's moderating tomorrow night?
No, it's supposed to be Theisberg, but he backed out. He called me today. He said, "Can you take it for me, Jake?" So it'll be me tomorrow with Gary Gunville backing me up.
Oh, good.
I hope Gary's planning on being there.
Okay, guaranteed a good call tomorrow night.
Thank you, Rick.
Nothing like putting a little pressure on your moderators, right?
This is probably news to Gary. He thought he was going to be.
That's what I was thinking too.
He thought he was going to be able to sit back and relax after last week, but sorry, buddy.
Oh gosh, okay.
I need you to be my wingman tomorrow.
And for
all right, I'm there.
Good. I know I can count on you.
I think you all know what that call is, but just in case you don't, it is it's the Inner Conversations call. It's open to anybody, any man with cancer of any type. Most of people on the call are prostate cancer survivors, but sooner or later we're going to have people with other cancers, and then the whole tone is going to have to change a little bit. But there you go. But it's a good call worth participating in, and it deals with the non-technical but the more emotional side of living with cancer. Guys, sorry we've run over, but it's only 15 minutes, not too bad. The next call is going to be next Monday, which is June already, June the 4th, and 8 o'clock Eastern time. We'll talk to you then. Good night, everybody.
Good night, Rick.
Good night, everybody.
Good night, Rick. Thank you, Rick.